So a routine visit to a medical spa for, what's supposed to be a quick wellness shot.
Right.
Recently resulted in an $800,000 jury verdict.
Yeah, and a patient facing, literally 4 decades of lost sexual function.
It's just horrifying.
Yeah.
Today we're doing a deep dive into how a trendy wellness procedure became an absolute medical nightmare. We're looking at the case of Hemi Herway, who went to B Medical Spa and Wellness Center for what they market as an O-shot.
It's the orgasm shot, yeah.
Exactly.
Yeah.
Administered by Dr. Nadine Haddad. And instead of this promised enhancement, she ended up with excruciating pain, life-altering loss of sensitivity, and this massive legal battle over medical negligence and, get this, the use of expired lidocaine.
Which is just, it forces a severe reality check on an industry that, really relies heavily on the aesthetics of relaxation.
Right, the spa vibes.
Exactly, the spa vibes. This case didn't just expose negligence during the actual procedure, it revealed this glaring systemic gap in how catastrophic complications are managed in the days and weeks after you leave the clinic.
And that actually brings us to the core mission of our deep dive today.
Yeah.
We're unpacking a pretty substantial stack of clinical guidelines, medical consent forms, and legal reports.
Lots of heavy reading for this one.
Tons of it. But we're doing it to answer one critical triage question. When a patient comes in for a post-O shot follow-up complaining of severe symptoms, what are the specific, undeniable clinical red flags that mean you have to mandate an immediate referral to a urogynecologist or a neurologist?
Because recognizing that boundary between, just expected mild post-procedure inflammation
Sure.
and a true medical emergency, that is where clinical intuition is really tested. And missing that boundary can literally alter the trajectory of a patient's entire life.
Let's frame this up a bit before we get into the heavy clinical literature, because the cognitive dissonance here is, it's kind of staggering.
Oh, totally.
These procedures are marketed in the exact same breath as getting a facial or, a chemical peel.
Right, it's just a quick touch-up.
Yeah. But you don't take a needle full of platelet-rich plasma and just inject it into the highly vascular, incredibly nerve-dense tissues of the anterior vaginal wall during a facial.
You really don't.
Patients and, frankly, some practitioners too, seem to suffer from this weird, localized amnesia about the sheer anatomical complexity of the pelvic floor.
Yeah, they really do.
They are performing invasive procedures on some of the most delicate, unforgiving anatomy in the human body.
Unforgiving is the perfect word for it, which is a vital point we have to establish. The pelvic floor is this really dense web of vascular plexuses and terminal nerve branches.
Right.
You can't just easily undo a needle stick in a nerve plexus or, easily evacuate a hematoma from a super tight fascial space.
So whether you're a clinician wanting to sharpen your triage skills or someone just tracking the regulatory Wild West of the wellness industry, or honestly, if you're just fascinated by medical ethics, this breakdown is going to map out the physiological reality behind those closed clinic doors.
Yeah, we're really looking at how a routine follow-up suddenly turns into a race against the clock.
Absolutely.
And to do that properly, we have to start by analyzing the immediate physical trauma that can happen locally right at the injection site. We need to evaluate the structural integrity of the tissue, basically the plumbing, before we start tracing the neurological wiring.
Okay, let's stick with that plumbing analogy then and look at the localized urogynecological red flags.
Okay.
Based on the literature we have, the O-shot involves drawing your own blood, spinning it down in a centrifuge to isolate platelet-rich plasma, or PRP, and then injecting that viscous fluid directly into the vaginal submucosa, the suburethral area, and the clitoral tissue.
Yeah, and the physiological theory they're selling here is that the concentrated growth factors in the PRP will, stimulate localized tissue regeneration and angiogenesis.
Which is the formation of new blood vessels, right?
Exactly. And because it uses your own biological material, clinics heavily lean on this claim that complications are exceedingly rare.
Right. It's completely natural.
Right. Their post-op materials usually state that light spotting or temporary numbness from the localized anesthetic or just mild discomfort are totally expected transient side effects.
But when you actually dig into the clinic triage guides and the fine print of the actual consent forms we have, the potential urogynecological red flags are catastrophic.
They really are.
If someone comes into a follow-up setting, an immediate referral to a urogynecologist is mandated if there are any signs of urethral injury. We were talking about a transmural puncture of the urethra.
Precisely. Because the suburethral space is incredibly tight. If a practitioner misjudges the depth or the angle of that injection by even a few millimeters, the needle can literally pierce the urethral wall.
Wow.
So in a follow-up, you aren't just looking for superficial bruising. If you see hematuria blood in the urine, you have to suspect structural damage to the urinary tract.
And the sources also emphasize that severe urinary retention is a massive red flag.
Oh, absolutely.
And we aren't talking about like a temporary feeling of urgency here. We're talking about someone who physically cannot empty their bladder.
Right, which requires us to look at the mechanism of that retention. It almost always comes down to hematomas.
Okay.
The anterior vaginal wall is supplied by a very rich, high-pressure vascular network. If the needle nicks a significant vessel, blood pools really rapidly in that confined suburethral space.
It just has nowhere else to go.
Exactly. It creates what we call a space-occupying lesion. So a hematoma in this area isn't just a simple bruise. It's an expanding pocket of blood that essentially acts like a tourniquet. It physically compresses the urethra, shutting off the flow of urine completely.
Oh my God.
And it compresses the surrounding microvasculature, which that can lead to localized tissue ischemia and necrosis if it's not surgically decompressed.
Which totally explains why the literature specifically flags patients with bleeding disorders or anyone on blood thinners as being at an exponentially higher risk for these massive compressive hematomas.
Exactly.
If a clinician sees these signs, the hematuria, the abnormal discharge indicating maybe necrosis or infection, the persistent radiating pain, they can't just be like, oh, take some Advil and use a warm compress.
No, absolutely not.
That is a structural emergency. You need immediate specialist intervention to relieve that pressure and repair the tissue.
And this brings us to, honestly, a major point of friction in how these procedures are presented to the public.
Yes. Let's pause on the actual consent form provided in the documents because I have to say, reading it is a surreal experience.
It's wild.
It is a bulleted list of risks, and they juxtapose severe catastrophic traumas like urethral injury and urinary retention right next to outcomes like constant vaginal wetness, mental preoccupation of the G-spot, or simply no effect at all.
Yeah, it completely slatens the hierarchy of clinical severity.
It's like reading a waiver for an amusement park ride that warns you might experience a gentle breeze, mild dizziness, or decapitation.
Yes, that's exactly what it feels like.
They are not in the same universe of physiological risk. How can you possibly provide truly informed consent when a structural injury requiring surgery is sandwiched between feeling overly aroused and having no effect?
It's baffling. And that tension right there is the central ethical dilemma of the aesthetic wellness industry.
Yeah.
Presenting risks in a flattened, casual format heavily minimizes the reality of structural damage. And structural damage in the pelvic floor rarely stays confined to just the plumbing.
Right.
Because of the density of the anatomy down there, structural compression almost immediately compromises our second major area of clinical concern.
Which brings us to the pelvic neurological danger zone.
The wiring.
The wiring, yes. The clitoris, the clitoral hood, and the upper vaginal submucosa are some of the most nerve-dense tissues in the entire human body.
I mean, they're designed for extreme sensitivity.
Precisely.
Yeah.
The dorsal nerve of the clitoris, which branches off the pudendal nerve, it packs thousands of afferent nerve endings into a microscopic surface area.
So a misplaced needle, or like we just discussed, an injection that triggers a compressive hematoma, it isn't just causing localized bleeding.
No.
It is actively threatening to crush or sever those primary communication lines.
Which can cause profound, completely irreversible neurological devastation.
Let's tie that directly back to the Jamie Harway lawsuit.
Mm-hmm.
Because her legal team stated she is facing 40 more years of an affected sex life. Basically, a complete loss of sensitivity due to this procedure and the expired lidocaine.
Right. But looking at the trial notes, the jury initially heard a request for $25 million in damages, but they ultimately awarded $800,000. And the reason why is fascinating from a clinical perspective.
It really is. The jurors noted in their post-trial comments that the plaintiff was never formally evaluated by a specialist who could clinically quantify the nerve damage.
Interesting.
Yeah, she lacked formal medical testimony from a neurologist or a specialized pelvic floor therapist who could definitively map out the exact nature of the numbness and the sensitivity loss.
That exposes a massive blind spot, doesn't it? Because she didn't get that highly specific neurological triage and follow-up mapping right away. The jury couldn't bridge the legal gap to award the larger damages.
Even though they fundamentally believe she was harmed by the clinic.
Exactly. It underscores why recognizing neurological red flags in that follow-up window isn't just about managing symptoms. It's about establishing an objective clinical baseline for profound injury.
It's the definitive argument for strict adherence to triage protocols. If we look at the American Academy of Physical Medicine and Rehabilitation, the AAPM&R guidelines, which really serve as a gold standard here, the immediate red flags that mandate an ER or neurology referral are sudden or progressive sensory changes.
Okay, so we are looking for a definitive loss of sensation, or on the flip side, maybe excruciating neuropathic pain that is worsening over time, not getting better as the swelling goes down.
Yes. But the most critical red flag, the one that indicates severe pelvic nerve or spinal cord dysfunction, is new onset bowel or bladder incontinence or retention.
Wow. Okay, let's trace that anatomy because that feels like a massive escalation.
It is.
If a patient comes in a week after an O-shot complaining of new bladder leakage or an inability to feel when they need to go to the bathroom, we aren't just dealing with local tissue trauma anymore.
No, not at all. You are looking at severe compromise of the sacral nerve roots, specifically S2 through S4, which innervate both the pelvic organs and the external sphincters. The AAPM&R guidelines dictate that if you see new onset autonomic dysfunction like that, you must consider an ED or neurosurgery referral immediately.
And the required clinical actions listed in the sources are highly specific. You need a bladder scan, urodynamics, avoiding diarrhea, and checking rectal sensation and tone.
Right. And checking rectal tone after a vaginal injection might seem totally counterintuitive to a layperson.
Right. They're like, wait, why are you checking there?
Exactly. But from a neurological standpoint, it is absolutely essential.
Because the pudendal nerve innervates both the anterior vaginal anatomy and the anal sphincter.
Exactly.
So assessing rectal tone serves as a direct proxy for the health of that entire nerve pathway. It tells the clinician exactly how far up the line the damage goes.
It's an excellent way to visualize it. You are trying to determine if the injury is just to an isolated peripheral branch or if a massive inflammatory response or a hematoma has compromised the central trunk of the pudendal nerve as it exits the pelvis.
Think of it kind of like a fiber optic cable network.
Oh, I like that.
Yeah, so if you're doing minor street construction and you nick a standard residential wire, you might get a flickering light in one room. That's your localized, temporary pain or spotting.
You're right. Annoying but contained.
But if your backhoe severs the main fiber optic trunk line buried deep under the street, the entire regional communication system goes dark.
Everything shuts down.
You lose all functional feedback. When you compress or sever these major pelvic nerves, you aren't just causing localized pain, you are cutting the autonomic communication lines for vital organ function.
And a bladder scan or a rectal tone assessment is basically how a clinician pings that fiber optic network to see exactly where the signal stops.
Which sets up a highly critical pivot in our triage protocol here. We just talked about nicking a nerve or compressing a local trunk. But the pelvic floor is also incredibly vascular.
Very.
What happens if that needle doesn't just hit a nerve, but pierces a major venous plexus and sends the injected cocktail directly into the systemic circulation? Because suddenly, what started as a localized clinic procedure can trigger life-threatening systemic neurological events.
And this is where clinical vigilance is paramount. If a patient presents at a follow-up appointment highly distressed with severe, kind of hard-to-pin-down symptoms, the guidelines dictate a thorough systemic neurological exam.
You can't just brush it off.
No, a clinician cannot assume it is merely localized pelvic pain or post-procedure anxiety.
So if we suspect systemic toxicity, for instance, if the lidocaine used in the procedure entered the bloodstream, what does that thorough systemic exam actually look like in practice?
The clinician must move far beyond the pelvis. They need to check muscle strength and tone across all four extremities. They must assess deep tendon reflexes, evaluate plantar responses, perform a sensory exam testing pinprick and joint position, and finally, assess the patient's balance and gait.
So if we are looking for upper motor neuron signs, we are essentially looking for a disruption in the central wiring, like from the brain down the spinal cord.
Exactly.
What does that actually look like in a physical exam?
A classic definitive test is looking for pathologic reflexes, specifically the Babinski reflex.
Right.
You take a blunt instrument and scrape it firmly along the sole of the patient's foot from the heel toward the toes. In a healthy adult, the toes should naturally curl downward.
But if those upper motor neurons in the brain or spinal cord are damaged or under toxic stress,
The big toe will bend upward and back, and the other toes will actually fan out.
Wow.
Yeah. If you see that fanning after a pelvic procedure, you know immediately that you aren't dealing with local nerve inflammation anymore. You have a systemic central nervous system crisis on your hands.
That's terrifying.
It usually presents alongside spasticity too, where the muscles are continuously just involuntarily contracted.
And the sources list several other systemic red flags requiring urgent emergency evaluation too. Syncope, or transient loss of consciousness, is a major one, requiring an immediate referral to cardiology or neurology for an EEG and arrhythmia monitoring. But the one that really jumps out to me is the potential for acute neuropsychiatric symptoms. We're talking severely reduced awareness, encephalopathy, or even psychosis.
Which perfectly illustrates the danger of intravascular injection. We refer to this as last local anesthetic systemic toxicity.
Okay.
If a toxic dose of lidocaine bypasses the local tissue and enters the venous system, it travels straight to the heart and crosses the blood-brain barrier.
Oh, wow.
Lidocaine works by blocking sodium channels. When it blocks those channels in the brain, it completely disrupts normal neural firing. And that leads to profound agitation, encephalopathy, psychosis, and eventually seizures.
So the psychosis isn't like a psychological reaction to a botched procedure.
No.
It is a direct pharmacological poisoning of the brain.
Precisely. And the guidelines also highlight positional headaches or a thunderclap headache, which is often described by patients as the absolute worst headache of their life.
Which indicates a sudden catastrophic shift in intracranial pressure, right?
Okay.
Potentially a subarachnoid hemorrhage or a vascular spasm caused by that systemic toxicity.
Exactly. And finally, you must assess for sudden onset cranial nerve deficits. If the patient reports a sudden loss of smell or taste, you are looking at involvement of venial nerves 1, 9, and 10.
Okay.
If you observe pupillary changes, asymmetry, or they report diplopia, double vision, that strongly suggests intracranial bleeding or an ischemic stroke.
I really want to ground this in the reality of the clinic room, because the differential diagnosis here seems incredibly fraught.
It is.
Put yourself in the shoes of a clinician doing this follow-up. You have a patient sitting in front of you who is extremely anxious, crying, and highly distressed.
Understandably so.
Right. They just had an invasive, highly personal procedure go wrong in a very sensitive area. How does a clinician objectively distinguish between a patient who is just hyperventilating from a severe trauma-induced panic attack versus a patient who is exhibiting true organic encephalopathy or early systemic toxicity that requires an immediate ER transfer?
It is arguably the most difficult, high-stakes differential diagnosis to make in an outpatient setting.
I can imagine.
And it requires clinical objectivity to completely override the emotional intensity of the room. A severe panic attack will absolutely cause a rapid heart rate, hyperventilation, tremors, and extreme distress.
Sure.
But a true organic neuropsychiatric red flag, like early encephalopathy from last, will present with a measurable objective reduction in awareness and cognition.
So they aren't just panicked, their brain is actually failing to process the room.
Exactly. They might not be tracking the conversation, or they might be totally disoriented to time or place.
Wow.
Yes, they might exhibit visual or auditory hallucinations or severe slurred speech, which, do not typically accompany an isolated anxiety attack.
Right.
You have to look for objective, unfakeable signs. Are their pupils reacting symmetrically to light? Is there a focal neurological deficit, like a subtle facial droop, or an inability to raise both arms equally?
So if they have altered mental status combined with any physical cranial nerve abnormality or an abnormal reflex like a positive Babinski,
You immediately bypass the anxiety diagnosis. You do not offer them a glass of water and tell them to calm down. You initiate an emergency medical transfer.
which brings our deep dive full circle. If we zoom out and synthesize the clinical literature, the legal realities, and the physiological mechanics we've unpacked today, it paints a very different picture of the medical spa industry.
A sobering one, really.
Yeah. We started with an intervention marketed as a quick, regenerative fix utilizing the body's own healing properties.
But the reality is a landscape of complex vascular and neurological risks. Risks that demand intense clinical vigilance and a complete mastery of systemic triage.
The primary takeaway here is that the boundary between expected post-procedure discomfort and a critical medical emergency is remarkably thin.
It's razor thin.
Differentiating between temporary localized inflammation and red flags like transmural urethral injury, sacral nerve compromise presenting as bladder retention, or systemic toxicity presenting as a thunderclap headache, it is absolutely vital for patient safety.
Yeah, these are not side effects. They are emergencies requiring immediate specialized intervention.
Right.
For anyone navigating this space, it strips away the spa music and forces a confrontation with the unyielding physiological reality of the human body.
It absolutely does. This exploration really equips you to read between the lines of glossy medical marketing and understand the strict, unforgiving anatomical rules that govern these procedures behind closed doors.
It's so important.
Which brings me to a final thought I want to leave you with, circling back to the Jimmy Herway case and that $800,000 verdict. We've read the consent forms. We know the catastrophic risks like permanent nerve severance, compressive hematomas leading to tissue necrosis, and the potential for decades of lost sexual function are known to the industry.
Right. They're quantified and printed in black and white.
So, at what point does the legal and moral burden shift? If a purely elective procedure carries a documented risk of permanently destroying the exact physiological function it claims to enhance, when does the conversation stop being about the practitioner's specific injection angle and start being about the fundamental ethics of offering the procedure in the first place? Where exactly is the line between a medical enhancement and medical harm? Something to critically evaluate the next time you see a casual advertisement for a quick wellness fix.